The first-line approval of pembrolizumab is going to require that we do first-line testing. That study was positive in a selected patient population that hit the 50% TPS score with the 22C3 antibody. And so we're going to need to look at that and really look at the details of the trial. So in getting back to the question about, well, why did the nivolumab trial fail and the pembrolizumab trial was positive, I think it's about selection. So we have to see the data, but the data is probably going to tell us that if you select properly, then it's better to start with pembrolizumab than with first-line chemotherapy. But in order to know who to select, you've got to test. So it's just like doing EGFR and ALK and ROS testing first-line before you start someone on treatment. We're now going to also need to look for PD-L1 expression by the 22C3 antibody. And at the Chicago meeting, we heard updates from a large community practice about what they're doing for their testing, showing that they're really not getting a tissue that would allow them to do PD-L1 testing in a majority of patients. And also not even being able to test all EGFR, ALK, and ROS, even in their adenos. And so in a research setting, in a big academic practice, we kind of assume, well, we all test, everyone's got to be testing, even though there are even limitations there as far as getting enough tissue. And I think as this becomes more widespread out in the community, we're going to have to really figure out how do we get everybody on board so we're getting enough tissue, and we're getting the pathologists to prioritize the tests that are going to help us change treatment as opposed to just the 10th antibody to prove that it's really adeno versus squamous, and not to disparage the pathologists, because obviously they need to make that distinction critically as well. But it's sort of all working together and speaks to the importance of having really good multidisciplinary discussions.